Military assessment and treatment protocols with Dr. Eric Scalise and Dr. Lee Bishop. You've met Eric before, as you know, a licensed professional counselor and licensed marriage and family therapist, and the executive or the vice president of American Association of Christian Counselors. And you've also heard from Dr. Lee Bishop. Dr. Lee Bishop, staff therapist at the Michael DeBakey Veterans Affairs Hospital in Houston, Texas. And also relevant to today's discussion is that Dr. Bishop is in charge of the group that takes OIF Iraq veterans, OEF Afghanistan veterans, and works specifically with these young returning warriors that have serious hidden wounds of war, in particular post-traumatic stress disorder. He in fact will use some examples out of his current practice that makes it very topical, very relevant. In addition, Dr. Scalise brings his whole experience of counseling to this discussion. We will discuss in this piece about assessment and treatment protocols is how do you assess it? There's something in the military called the PDHRA, the Post-Deployment Health Risk Assessment. It's a way to try to assess, and one of the challenges is that as troops come back from the war front, the last thing on their mind is a health risk assessment, a mental health assessment, and so they do it very quickly sometimes, and it doesn't indicate what is necessarily going on in their lives. And so there's other means of acceptance, and perhaps the first touch point at the Veterans Affairs or within the military medical system, or sometimes the first touch point is in a church or a community organization. And so in their discussions, they will talk about the importance of teaming, the importance of partnership, the importance that many hands make light work, and the importance of community, particularly given the significant Guard and Reserve mobilizations of this ongoing effort. And again, I would ask all parties that listen to this to view it through a wide lens, understand the broad applicability of the treatment methodologies we see in the military, in many ways sometimes as a forerunner of the treatment methodologies that you may find useful in your own practices that may not always relate to the military. So I give you now Dr. Eric Scalise and Dr. Lee Bishop.
Hi, and welcome to this session. I'm here today with our guest, Dr. Lee Bishop, who is a staff psychiatrist in Houston with our returning troops. And Dr. Bishop, Lee, it's great to have you with us. And today we're going to be talking about assessment and treatment protocols, specifically as it relates to the military, our veterans, our returning troops. So let's start with the assessment side of the equation. As you think about what you do as a staff psychiatrist and your team there in the VA Center, what would you say are the critical core issues that you must take into account as you're assessing your patients?
Well, I think first of all, we want to get a good sense of specific describable symptoms that the individual presents. It's only with a clear understanding of those symptoms that we can really make a diagnosis, whether of PTSD or depression or some other form of anxiety or mood disorder, or perhaps if there's substance abuse involved, being able to make that sort of diagnosis as well. So it's very important at the outset to facilitate the individual in describing what their experience is. Sometimes that involves also talking to people around the individual, family members who can oftentimes provide information based on their observation that the veteran or the service member themselves may not have been aware of. Particularly, for example, taking one example, sleep is a very important issue. And very often spouses can tell us something about the sleep behavior that, of course, the veteran often or the service member often cannot be aware of themselves.
I imagine it could either be a lack of awareness, or in some cases it might just be denial, not wanting to acknowledge that a person is struggling with a particular set of symptoms.
That's often very true. Very often the service member or veteran doesn't realize, for example, how their irritability and difficulty in managing anger, which often is one of the real changes that family members and friends pick up when they've returned from the combat zone, they often themselves don't realize that it's affecting people around them in the way that it is. And getting that feedback from family members, sometimes from friends or associates, can be very helpful.
I suppose, in one sense, it's difficult to extinguish or resolve a treatment issue until you can distinguish or identify that issue.
Well, that's absolutely true.
Right.
You know, the old rule in all of medicine is you can't effectively treat something if you don't know what that something is.
Right.
Diagnosis has to come first. You have to make as accurate a diagnosis as you can, and then the treatment, then, while it may not altogether be obvious, it certainly is going to be much more on track than if you start out with a wrong diagnosis to begin with.
And as you think about the combat trauma spectrum, because there will be a continuum of symptoms leading to more severe end of the diagnostic scale, how important is it that you identify where that person is along that spectrum, on that continuum? How does that relate to eventual treatment decisions that you'll make as a team?
Well, as they're at the milder end of the spectrum, then as common sense might dictate, one might not have to involve as many of the more intensive and frequent clinical encounters with that individual to successfully treat the disorder. With more intense symptoms, with more of the symptoms of a given disorder, say of post-traumatic stress disorder, then very often that may indicate a more comprehensive and more intensive approach to treatment. For instance, with milder PTSD and depression, we may see those individuals on a once every couple of weeks basis for some psychotherapy. I may see them once every 3 to 4 weeks for a medication check.
Right.
But individuals who are having much more intensive kinds of symptoms, having difficulty functioning on a day-to-day basis, going to work, relating to family members in the way that they want to and need to, those individuals may need to be involved in sessions multiple times a week.
Mm-hmm. How common is it to see, as you're making this assessment along the scale, to see suicide potential or risk? I would think that would be one of the things that would be a marker for you, that you would specifically look for in people you might suspect of having PTSD or are returning veterans that are coming back.
Certainly, the safety of the individual is a priority, and so one of the first things that we want to do at the very outset is to get some sense of whether that individual is a risk to themselves. Either because they're having an actual suicidal crisis with a plan, or perhaps just someone who feels like that they have lost the purpose for living and maybe haven't even thought of suicide in a serious way, but nevertheless is having those thoughts. So we want to assess that at the outset and get a sense of how high the risk is for harm to self, and do what we need to do to make sure that individual is safe.
I would assume there are times that hospitalization might be required.
Indeed, certainly in those cases where an individual has an active plan for suicide, is having an impulse to harm themselves, then we think seriously about putting them in the hospital.
Or
at
an
that point.
endangerment to others.
Correct. And I guess I would add to that the vast majority of our veterans with post-traumatic stress disorder don't pose a danger to themselves, and the vast majority do not pose a danger to other people. But if that danger is there, we want to spot it very early on.
Certainly. There are two terms that in this trauma spectrum that are often out there that our listeners may be already familiar with. One is TBI, or traumatic brain injury, and the other is post-traumatic stress disorder. And there are some overlapping symptoms between those two categories. How do you assess and determine exactly what you're dealing with? What are some of the things you would do to determine the accuracy of a diagnosis?
Well, again, symptoms can point you in the right direction.
Sure.
For instance, there are indeed a number of overlaps. Individuals with traumatic brain injury and individuals with PTSD oftentimes have difficulties with mood swings, with depressed mood, problems with concentration, problems with memory. Some of the things that help me when I'm interviewing the patient is to find out, first of all, did they have a significant brain injury, either close exposure to a blast, which is quite frequent in the combat zone in both Iraq and Afghanistan. Did they have a fall that was significant? Did they have any blow to the head where they either lost consciousness, or maybe even if they didn't lose consciousness, had their bells rung or saw stars or were dazed for a period of time after that? Then symptoms such as chronic and severe headache, symptoms such as sensitivity to light, those more physical symptoms are less likely to be seen if you're dealing just with PTSD. If those have continued, you want to think strongly about the possibility that TBI is present. Now, that alone is not enough to make a diagnosis of TBI. That simply tells us that the individual needs to go to the next step of screening.
And would that often include some neurological, psychological testing to verify?
It would. Typically what we will do in those cases is get a neurological exam performed, which is a specialized form of physical exam that checks things such as reflexes, sensory difficulties, motor, muscle abilities, and so forth. We'll also usually get some form of brain scan done with that. And in addition, then the individual often will go through a battery of more refined neuropsychological tests that can give us a clearer understanding of the kind of impairment that the individual is having with functions such as memory and concentration.
Lee, I think you're pointing out an important factor, an issue that all of us have to keep in mind, is that different people have different areas of training or expertise, all the way from lay helping, pastoral counseling, to psychological training, to medical training such as yourself, and sometimes it takes a treatment team approach to be able to come up with what's accurately going on, and to also understand that might be beyond me, and it would be wise to get as much information as possible. As a therapist myself, I've often said, listen, I think you need to go see a doctor and have a medical examination to rule out or to rule in certain things. And so I think that's probably important as we're talking about assessment protocols.
It is. We take a team approach at the VA.
Right.
Our particular team is composed not only of myself and one other psychiatrist. We have 3 psychologists, a social worker. We expect that team will even grow in the future. But each of those members, by virtue of their discipline and training, bring special abilities that not all the members of the team have. Right. And our combined efforts are stronger than our individual efforts alone.
Now, when a patient presents themselves at the VA, do you have any sense of how long after a return from a deployment a troop might be back before they may seek out care? Are you looking at immediate cases? Are you looking at cases that have perhaps lingered undetected or untreated for months, for years? Any standard there?
Well, we're seeing the whole spectrum. We're
Right.
certainly seeing some that have come back from deployment within just a few weeks of our first encounter with them. Unfortunately, we see some that have been back from deployment for a long time and for whatever reason have not come into the system. As I mentioned in my earlier conversation with Bob Dees, we are at the VA are making a very proactive effort to make contact with all the veterans that are coming back from Iraq and Afghanistan currently. And I think that's helping us get them into the system much earlier than we have perhaps in the past. But no system is foolproof, and the thing that we face is that in many cases some of our veterans are uneasy or uncomfortable about coming in to get that assessment, and even in spite of our best efforts don't get in as early as we would like.
Now, a common secondary issue that people come in when they have experienced traumatic stress or may in fact have PTSD or TBI are substance abuse problems, perhaps alcohol or other drugs. And so talk with me for a minute about when someone comes in and we know they have a drinking problem or some other substance issue going on, how do we assess that in the overall assessment picture, and what do you address first and why?
Well, I always, in my initial session with a veteran, ask them about substance use. I ask them specifically how much they're drinking, if they are drinking at all. And I think it's important for counselors to do that in a way that gets a very clear quantity of that. Sometimes counselors, particularly young counselors, will be satisfied with an answer such as, oh, I'm drinking a little bit but not much, or oh, it's just social drinking. I always ask them to tell me what they mean by social drinking in terms of how many drinks per week or per day.
Because some people may minimize what in fact is going on.
Exactly,
right? Sure.
Yes, and studies have borne out that there's a tendency to do that. I will ask them specifically about use of any typical substances of abuse, marijuana, cocaine, amphetamines, and try to get a very clear history on that. If I suspect that there is more history than the individual is willing to convey at that point, then if I have permission to speak with a family member, I'll ask them about that and what they have observed. I like to get that established very early on, because the experience of most clinicians in treating post-combat PTSD and depression is that as long as there is substance abuse ongoing and active, that the treatments for those conditions are not going to be very successful. And we're increasingly beginning to understand that there really are matters of brain physiology and brain chemistry that account for that the treatments that we have are helping the brain to repair itself, if you will. Right. And the substances that are being abused are actually blocking that process in many cases.
So when you have a dual diagnosis or a comorbid condition, for the proper term, the treatment protocol would be to address the substance issue first, so you can remove those issues off the table, so as you're addressing other neurological functioning, especially when it comes to medication issues, you know exactly what you're dealing with. You know that whatever's going on neurochemically is not related to the substance.
In essence, that's correct. The way I would put it is that we don't necessarily delay treating the PTSD, right, but we make it a priority to have that individual in treatment right for their substance abuse at the same time, because as we say to them, if you're not getting the substance abuse treatment and you're not getting in recovery from your substance abuse, then what we do for you for the PTSD, we can still do that, but it's not going to be very effective.
Okay. Let's shift gears for a minute.
Sure.
We've talked a little bit, unless there's anything else you want to say about assessment. Okay. Let's shift over to the treatment side of the equation. You've done your workup, you've done your evaluation, if you've done a neurological or psychological profile, you've received some input from family, from spouses. What happens next? How do you formulate that treatment plan? What are the first steps that you will do next?
Well, the first steps are for the team members to communicate with one another, to pool their information, to discuss the case, and then to determine, based on that individual's needs, based on the intensity of their symptoms, what kind of treatment plan, what intensity of treatment plan is going to work best. We actually draw that up in a written treatment plan that's part of our documentation.
And you share this with the patient?
And we do share that with the patient. We explain to them the rationale for the treatment, why each component is important. Maybe it's most informative to maybe talk about a more severe case, because that would involve more of the kind of treatment that we have available. Let's say that we're dealing with an individual who is having very severe symptoms of PTSD that are disrupting life on a daily basis. They're experiencing frequent nightmares, frequent flashbacks, avoidance symptoms, so that they are avoiding public places, avoiding any situations that remind them of the trauma. And let's say that that's an individual who's perhaps, even if they're not suicidal, have had some suicidal thoughts, are having panic attacks perhaps on a frequent basis, and all these things are making it difficult for them to get out and pursue gainful employment or to relate to family members in a way that's healthy and supportive. For that individual, typically we would probably recommend that they be involved in some form of individual psychotherapy that initially might be fairly frequent, once or twice a week. Another very important piece of a whole treatment package is, as simple and common sense as it may sound, is sometimes forgotten, and that's just educating the service member, the veteran, about the PTSD or the depression, helping them to understand why they have these symptoms, how long they can expect to have them, what a realistic expectation about the outcome of treatment is, and maybe especially helping to educate spouses, family members about this and what they can expect to see.
That goes back to the principle of consent and disclosure at the very beginning, because what you're trying to create is a sense of ownership.
Yes.
With the patient, with the patient's family members. I suppose it's because human nature is we tend to take care of what we think belongs to us.
Yes.
And if a person can, in essence, own what's going on with their life, my sense is that as a treatment professional, as a physician and a treatment team, you would see a person engage more readily into the treatment process. And so let's talk a little bit about that education piece for a minute. Not just post-deployment, post-symptom evidence, but let's talk about pre-deployment education for a minute as actually a pre-treatment or an inoculation of sorts. We certainly inoculate our troops physically for a number of things. What about sort of an emotional, psychological inoculation? Where does education fit in terms of a pre-treatment protocol?
Well, it's very important. The more that the service member can understand that these symptoms are not a rarity, that exposure to combat events can lead to brief episodes of symptoms similar to PTSD or may lead to PTSD itself, I think it takes away some of the fear and the anxiety about the condition itself. And it also helps communicate to them that the bravest and best can and often do experience these things, and that it's not a matter of their being weak in character if they do. What we want to do is to set the stage for them to be able to acknowledge that those symptoms are there, which is one of the hardest things for a service member to do very often.
Sure, especially in the military culture, perhaps.
Certainly, certainly.
And with that sense of ownership, as you said, perhaps it helps reduce anxiety not only for the troop, but perhaps also for their family members, because they are at home trying to prepare for that return, and they remember their husband or wife or their son or daughter in the condition that they were emotionally, psychologically, spiritually, socially before they deployed.
Yes.
And so without some education and awareness for them, that may increase some secondary or vicarious trauma as they're now observing for the first time, perhaps after months or longer, face-to-face reality of what that experience has done for their family member.
That's right. And that education also helps them understand that there's a difference between, say, PTSD versus the whole set of habits of mind that their training and their experience in combat have engendered in them. The Army has come up with the concept of battle mind, which I think is very useful for our service members to think about. And that concept simply encompasses those habits of mind that one has to have to survive and to help one's fellow service members survive in the combat zone. In the combat zone, those habits of mind, the vigilance, the being in control of details, and a number of other habits of mind are important. One has to have them to be a good soldier, sailor, or Marine, or airman. But unless one is able to begin to relinquish those coming back into the civilian environment, it can cause a lot of turmoil and trouble.
Let me go back to something you said just a moment ago, Lee, about when people exhibit symptoms or signs of traumatic stress or PTSD, it's not necessarily a failure of character or even sometimes even a willful choice that people are making, but a trauma, especially depending on the severity of that trauma, can alter brain chemistry. And so certain things can be set into motion that are perhaps beyond a person's initial willful choices, and yet they may feel very responsible for that and bothered by the fact that they can't automatically shut those things down and change direction.
That's right. You know, Eric, it's very common for me to hear from a veteran statements such as, you know, I don't want to do these things. I don't want to lash out in anger at my family, at my wife, at my husband. It's like I have no control over it or don't have as much control as I used to have. And what I explain to them is that this is not just, if you will, a psychological condition. Increasingly, based on our studies, we're coming to understand that PTSD represents really a change in function and maybe even to some degree in the actual anatomy of the brain. We think that the exposure to high levels of stress hormones that occur day after day after day in the combat zone is creating a process that's going on in the brain, and it's changing some vital elements of brain chemistry.
Right.
There's even some preliminary data that we probably have to get more confirmation on, but there's some data at this point that suggests there are crucial areas of the brain that are actually being physically changed by this. And so what we have really is a true brain or neurological condition going on with PTSD.
And because of the release of the adrenaline, the cortisol, you know, those hyperarousal chemicals in our body to handle that stress, it hijacks the messages that are intended perhaps for the neocortex, that thinking part of your brain, and immediately goes to the limbic system, or your feeling part of your brain, and all of a sudden you're feeling powerful things and not always thinking clearly in the middle of that crisis or trauma.
That's right. And we also think it helps us explain a lot of the difficulties with memory that are being reported by individuals with PTSD. In some of our studies, we've seen that a very important part of the brain that helps to modulate memories is actually shrinking somewhat. And we think that explains why we're seeing these things.
Let's talk about something associated with that for a minute, because if you're talking about neurochemistry being altered or changed, as a psychiatrist, as a physician, I'm sure that medication regimens are part of your treatment protocols and your standard operating procedure depending on the diagnosis. How often do you prescribe medicine? What medicines perhaps are particularly helpful for traumatic stress or PTSD? And then I'd like to ask a follow-up question about issues of faith as it relates to medication.
Sure. Well, we are using medications quite frequently in all but the mildest cases of PTSD and the depression that oftentimes is associated with PTSD. The class of medications that we're finding most useful are actually what we call antidepressants, but in a way that's probably a misnomer because they're really antidepressant and anti-anxiety agents as well. Most of these medications are ones that impact on the serotonin neurotransmitter system in the brain. That is to say, the brain works by chemical messengers, and one of the most important of those is serotonin. These medications, by and large, work to help serotonin be more available at critical parts of the nerve pathways in the brain, and they're probably doing a great deal more than just that as well. The typical things that we can expect to see when we start individuals on those medications are for instance, reduction in irritability is very often one of the first things that I will hear reported. Improvement in mood, reduction in panic attacks and severe anxiety. So these medications are helpful for a variety of different symptoms.
So they increase the presence and the availability of the serotonin for the right messages to get to the right places at the right sequence and the right time.
That's correct. There are additional medications that work on different neurotransmitter systems, but basically they all are going to hopefully accomplish the same end.
Are there certain common medications that are out there that, you talked about ones that impact both depression and anxiety? Would Wellbutrin be one of those, or what are some of the medications that you see that you use or prescribe most frequently?
Probably some of the most frequent ones that we prescribe in the VA system would be citalopram, also fluoxetine, respectively. That's in trade name Celexa and Prozac. Paroxetine is another, sertraline another one. Wellbutrin or bupropion oftentimes can be very useful as well.
Okay. I've had Christian faith-oriented clients before. I'm sure you've had patients who are very active in their Christian faith, and the thought of taking medication as a treatment may sometimes cause some stress for them as they think about matters of faith, because they may feel that since I'm a believer and I'm supposed to be trusting in God, why can't I manage my thought life? Why can't I manage this roller coaster of emotions going on inside me? I should be able to do that. And so sometimes within the faith community, there's even a resistance to medication as a treatment option because of that. Can you speak to that to a minute?
Well, first of all, I'll say that Jesus acknowledged that the sick need a physician.
Yes.
And the other thing that I would say is that of all of creation, the most complex piece of matter that God created is that right between our ears. There's nothing out there in all of space and all of the black holes and the galaxies that is as complex and intricate as the matter that we have that we call the brain
Right.
and the central nervous system. Because our behavior, our emotions are to a great extent tied to the health and good functioning of the central nervous system, it's natural that at some point, probably for all of us, whether we've been in combat or not, that there may be some degree of mild and in some cases more severe problems with that physical structure that can either lead to or be found in conjunction with depression, PTSD, anxiety disorders. And so when we give a medication, I think it's important to understand, first of all, that most of these medications, the vast majority of them that we use, are not addictive. They're not intended to snow the individual or to take away their normal behavior.
Right.
And in fact, a good psychiatrist, when he or she sees the medication is having some side effect like that, they don't want it. They want to find something else, some other medication that's going to actually help the individual to function normally.
I've often heard it described that traumatic stress, major depression, it's like being in a small rowboat out in the open sea in a bad storm. And the wind is blowing, the rain is coming at you sideways, and you're just trying to survive. You're bailing water. You're not going anywhere. And what medication can do is help calm the storm, but it won't row your boat anywhere. There's still work to be done, but medication can sometimes help calm the storm to give you now the foundation or the basis in which you can do some cognitive work and work through some of the issues in a more productive way.
That's a great analogy.
So in combination with medication, often one of the most common treatment approaches is some sort of talk therapy. Many therapists employ what we call cognitive behavioral therapy. Let's talk about that for a minute. You mentioned that you have psychologists and social workers that work in a team format. How much do you utilize talk therapy and cognitive behavioral principles in your treatment approach?
Well, it's one of the more common forms of counseling or psychotherapy that we use. It's got the greatest body of research supporting it in terms of its efficacy, and has long been one of the staples of treatment for a variety of anxiety disorders, including post-traumatic stress disorder. Cognitive therapy is based on the understanding that when we experience an event, say a traumatic event, and then we have an emotional response to it, it's based on the recognition that between that traumatic event and that emotional response, there is a thought process. It may be a very rapid thought process. It may be one that we're hardly aware of in many cases, but that there is a thought process there. And that sometimes thought processes, ones that are not rational or maladaptive, can become a habit for us. And because they're maladaptive, because they are perhaps not viewing reality as accurately as they could, may lead to emotions that aren't very helpful.
Right.
Such as depression
Right.
or unnecessary
And
anxiety.
emotions impact behaviors, and ultimately behaviors will impact things that are happening at a relational level.
Exactly.
And a lot of times people come into treatment because something is not going well at some relationship level. Maybe it's a marriage or something going on within the work environment or family environment. But after you start digging down a few layers, you start seeing what in essence become processing errors. And so cognitive therapy in combination sometimes with medication where it's appropriate can help people sort out and maybe reprocess those traumatic events in a way that helps them get unstuck, move beyond it, find new ways to adapt, to live. Which let's talk for a minute about where faith comes into that, and using Scripture and the truth of God's Word, the ability, as the Scripture says, to renew one's mind. I think that's why within the Christian context, the concept of cognitive behavioral therapy works so well for people?
Well, I think that's true. I think that what we are trying to do with cognitive therapy is to change those habits of mind. And one of those perspectives or habits of mind that can be most important to change is one that gives hope.
Sure.
And clearly individuals with depression, very often individuals with PTSD, have little hope, either for the future or ultimately about the meaning of their life, their existence. And so I think it's important when they have a faith foundation for that hope. It can be very important in helping to move beyond that hopelessness.
Right. Because when life doesn't make sense, you need to have something to anchor your soul to, a foundation to stand on for many, and it is God's Word. And then there are other tools that utilize faith-based or scriptural materials. The Combat Trauma Healing Manual that is part of who we're partnering with this series is an excellent example of how to utilize some scriptural principles and help people work through some cognitive material integrated with Scripture. And so tools like this are helpful in a faith community. I would imagine important to the overall treatment program that you're trying to implement for people of faith where that part of life is a significant part of who they are.
Yes, it can be.
How about pulling in resources outside of your team? I used to tell my counseling students when I was training them that they would have a client for perhaps 1 hour a week, maybe 1 hour every other week, but that person who's hurting, especially someone experiencing PTSD or trauma, may need a lot more care, a lot more support, a lot more resources that because of time and other factors, I can't give them but so much. So how do we incorporate other resources? How do you do that through the VA? Do you do that? What are some things that are out there? Because I think this is where the church could step in to play an important role.
Well, you know, Eric, we've long recognized that having a community of individuals around oneself as one's going through difficulties in life, having a community of people who share in supporting one another, who themselves have been through, if not exactly the same difficulties, at least the difficulties that we all face in one form or another in life. Having that community is an important part of recovery. To take AA just as one historical example,
Right.
AA has really tapped into that idea and developed it into a very effective healing and recovery tool. In the VA, we can do that for limited periods of time, both by having an individual in the hospital as part of that community of patients that's in treatment in the hospital, but for most people that's going to last a very short period of time, a few days or maybe a couple of weeks in most cases.
Right.
We can have them in a community of veterans that extends over a longer period of time, an intensive outpatient program where they're attending groups and so forth. The advantage of a faith community is that they can continue as long as they want with that community.
Right.
They can find ongoing source in a network of fellow believers that also enfolds their family
Sure.
in that community. And I think in that way, over a period of time, they can really sink deeper roots than they might be able to do in many cases in a treatment setting. So for those individuals, those veterans and service members that either already have a connection with the church or contemplating some relationship with a faith-based community, in general, I will encourage them to pursue that. and find ways that they can use that as a real source of support for them.
The research out there shows that when a person is treated within the confines of their basic core worldview, that the engagement into the treatment process and the results and benefits out of that treatment process are enhanced when people feel it's in alignment with where they are in terms of their worldview and their faith.
I think that's true. You know, one of the concepts that is gaining increasing importance in psychiatry, in psychotherapy, is the whole concept of mentalization. And that involves the ability of the patient not only to begin to have an appreciation of the mental processes in other people, but also to know that they are understood, empathized with, that the therapist and caregivers with them have a sense of what they're experiencing subjectively. And so I think that points to the importance that having a sense of connection around one's worldview it has in the whole process.
It's like bringing the whole community into the picture to help treat the whole person.
Yes.
And then one of our hopes out of this entire series is that people will have some of the education and training they need to be able to develop, utilize resources like the Combat Trauma Healing Manual, or to start support groups that they can start in their churches and ministry organizations that will help provide such needed services, you know, to our returning troops, to our veterans, who perhaps have been suffering with some form of traumatic stress or PTSD for years, but never stepped forward or received any kind of benefit. And I just believe that the church is uniquely positioned within a community to offer, as you said, that ongoing support network as a person leaves treatment. Because you and I both know as professionals, whether it's medicine or therapy, sooner or later the therapy is over. The sessions are done. People are now stabilized on medication, but it doesn't mean that they don't need ongoing treatment support.
That's true. And there's another issue too that I think is very important, and that is that as faith communities become educated about these conditions, as they come to understand more about the effects of combat and military service on the veteran and the service member, I think that helps to combat the stigma that is associated with PTSD and depression.
We're a culture that's so quick to label people.
Yes.
We call people an alcoholic, an addict, or whatever. And I think what we have to remember is we're dealing with human beings, and we're talking about symptoms, we're talking about behaviors, but we have to help people recognize that they are uniquely created in the image of God for a plan and for a purpose in life, and to be able to look beyond the symptoms, beyond the diagnosis. I understand in the medical world and in the clinical world we have to use diagnostic categories for various reasons, but ultimately we need to get beyond that and look at the person.
Yes. You know, it's often said that the church is a hospital for sinners.
Right.
Well, I think that when a healthy, well-functioning faith community is able to enfold within its membership, within its community, those individuals who are suffering from conditions such as PTSD, which we should say is not just combat veterans.
That's right.
Many different people can.
That's right.
And conditions such as depression and the whole array of mental health conditions. There's a way in which that idea of the faith community as a hospital really takes on a very concrete kind of sense. And it can become, that faith community can become a true healing community.
A MASH unit.
In a way of speaking, yes.
Right. Well, Lee, Dr. Bishop, it's been just great to have someone of your expertise and knowledge and background and experience, sharing your insights and your thoughts and your experience with us about traumatic stress and PTSD, especially for our military troops, both who are about to be deployed, those returning from deployment, those who are veterans and perhaps have never received care, but you're interacting. So thank you for being with us. And so as we close, I would just want to ask you, is there any closing thought, comment that you would want to share with those that are listening, our counselors, our pastoral caregivers, our professionals, that you would just want to encourage them with?
Well, I think first of all, one of the most important things that both our service members, our returning veterans, and faith communities can do is simply to educate themselves about these conditions. Part of the difficulty with stigma is the fact that there are myths that continue to float out in our society about these conditions. And to the extent that we can all understand them better and address those myths, I think in that way we can serve and honor the tremendous work that our men and women in services have done and support them in the years to come.
Well, thank you. Wise words, great words to close on, and thank you for being with us today.
Thank you, Eric.
Dr. Clements, tell me about what you do that's very unique to the Clements Clinic and some other clinics in terms of the brain scanning or SPECT scanning.
Right, I'm an adolescent and adult psychiatrist, and I do brain imaging, particularly SPECT brain imaging. And SPECT stands for single photon emission computed tomography. And that's a big word. Basically, what these scans do, they look at your brain's functioning. So they look at the activity levels in your brain. Okay. So it tells me three things: areas of your brain that are working good, areas of your brain that aren't working hard enough, and areas of your brain that are working too hard. And now there is a little bit difference in these scans and what you normally think of as brain scans, a CT or an MRI scan.
How are they different?
Right. Those scans, CTs, MRIs, show your brain's anatomy. These show, the specs are another type that show your brain's activity or its functioning.
And so what you're talking about is when your brain is working, certain areas of it are working, maybe working more actively than others or less actively, you can see that on the SPECT scan.
We can see the activity levels.
And why are those type of scans, that type of image of the brain, why is that important to the field of psychiatry and diagnosis and treatment?
Well, what we see is that most psychological problems are not problems with your brain's anatomy, but they're a problem with your brain's functioning. So most of the time, CTs, MRIs on a patient with psychological problems will come out normal. So it's really the functioning that you have to look at. Another reason is you can't just look at somebody and tell what's going on with them. It's guessing. And one statement I hear all the time is that psychiatrists, they're the only specialty in medicine that doesn't look at the organ they treat. And that's true, but these scans do give us a way to look at the brain and how it's working.
Todd, could we maybe take a look at some of the scans that you've done and help explain to us what happens to a person's brain in trauma, and then the things that you see in someone who would have trauma or PTSD?
Sure, I think that would be very helpful. Here is a scan. We're going to start with a normal one just so we can kind of see where we are. And I've got a small model brain here, so hopefully that will help orient you. But what we're looking at is the SPECT scan of a normal SPECT scan of a female in her 20s. And it looks at different views of the brain. We're going to just really focus on this one right here. We're looking at the brain from the bottom up. And we see three different colors. The calmer areas of your brain are blue, and then as your brain gets more active, you've got red. The most active area is white. So we'll call this hot. The more active your brain gets, that's kind of the terminology we use, the hotter it is.
And so in this normal brain, is it the sort of the back area of the brain that is normally, in a normal person, the most active?
Exactly. If you look here, the green part, the cerebellum, it's normally has all the white and most of the red. And the reason being, the neurons are very packed in this area of the brain. In fact, this area of the brain makes up 10% of the brain's volume, but it has about 50% of the neurons.
Wow.
So now when you look up in the other areas of the brain, you want to see blue mainly. I don't mind seeing spots of red here and there, but I don't want to see any white in the other areas of the brain.
So no other hot spots
Exactly,
in the brain.
exactly. You don't want to see any hot spots there. So this was a 22-year-old female who was brought into us actually by her parents. She didn't want to come. And 2 years earlier, she had been living in a halfway house situation and had been repeatedly physically abused. Had also been sexually traumatized as well. And
so some pretty severe cases of trauma.
Exactly, and the parents said, you know, it's totally changed her personality. You know, she went from this, you know, happy-go-lucky, you know, teenage girl to now she's depressed all the time. She's very irritable. Her parents described her as that she's chronically mad. They said
that chronically mad statement, I've heard that about a lot of people that have been diagnosed with PTSD, especially some of our veterans, our military personnel, that anger, kind of chronic anger is a real symptom of PTSD.
Exactly. Anger is one of the things that they would say. They said she really had no motivation or drive. In fact, she spent most of her day at home, wouldn't leave the house, watched TV most of the day. I mean, parents couldn't get her to go get a job. She would talk about wanting to go to college, but then she couldn't even fill out an application form, couldn't even get that far. She had panic attacks, had suicidal thoughts. She would have periods of binge eating. So, I mean, there was just a ton of stuff. I mean, this girl was a mess. So, and when we looked at her brain, I mean, lo and behold, you can definitely see some areas of abnormal activity. You can see a lot of white in the brain right here.
Now, explain those colors that we're seeing there and what that would mean in terms of what function in the brain and how that would relate to the symptoms that you were describing.
Exactly. Now, if you look right here in the middle of the brain, this is an area we call the deep limbic system. And you can see that there's a lot of white in this area, so it was too active. Now, this is an area of your brain that has a lot to do with your emotions. In fact, it's the area of your brain that emotionally tags events.
There's one other thing that we've seen reported a lot, and that is traumatic brain injury.
Right.
A lot of the vets coming back have had injuries to their brain, and I know that's something that you're also able to work with very specifically. Tell me a little bit about how you use the SPECT imaging with people who have traumatic brain injury.
Well, here again, they're saying, last I heard was they estimate 1 out of 5 soldiers that comes back from Iraq will have a traumatic brain injury. And one things we find is here again, these are people you can't just look at them and tell. I mean, they, you know, look regular. They may, you know, they're smart, but you know something's not right with them. They're not the person that they were. And here again, with the SPECT brain imaging, it's going to be very sensitive to show if there's any trauma. What we find, CTs, MRIs, they're looking at the anatomy, so it's not nearly as sensitive. So you can have a head injury, but the anatomy still be fine in your brain, but the functioning won't be. And here again, what area of the brain you have a traumatic injury has a lot to do with how we treat it.
Todd, I know that men's and women's brains are somewhat different structurally in how they function. Would that lead there to be differences in men and women who develop PTSD? There
are. You know, actually, females have a larger limbic system, and that was the area of the brain that we talked about that has to do with the, you know, expressing emotion. So that's why, you know, females are probably more in touch with their feelings, or better able to express feelings. That's the area of the brain that has to do with bonding with people. So
a little better relationally.
Exactly. Well, there's no society in the world today where men are the primary caretakers of children, and that probably has to do with the limbic system. But what this has to do with emotional trauma in PTSD is it's going to make females more susceptible to emotional trauma and post-traumatic stress. Now, sometimes this is a surprise because many people think of, you know, post-traumatic stress disorder. That's something that men get, you know, soldiers in particularly, or, you know, somebody that gets, you know, shot at. But you're seeing more women. And why is this important? Because when you look at the combat today, we have more women than ever before that have been in combat.
And that, are we probably then seeing higher percentages of those veterans who are women being more susceptible to and maybe having higher rates of PTSD?
Yeah. From what I hear, we actually are, as far as like veterans going homeless, that there's a higher percentage actually, you know, compared to men of females that's happening to. Now, one good thing is women will tend to be more open to going to get help.
Yeah.
So now that's where the men have problems a lot of times. You know, usually when a man with post-traumatic stress shows up to see me, it's already after, you know, alcohol or drugs have been added on as a way to self-medicate. And because there's, you know, still the stigma with men, you know, if I go admit something like that, then I'm weak, you know.
So even though women may be more prone to PTSD because of our larger limbic systems, that larger limbic system also makes us more willing to relationally reach out for help and support. And as you've said, that's one of the most powerful treatments or things that facilitate healing from PTSD is that connection and support with other people.
Exactly.